What's really fascinating is the more I've shared my own story with recovery, every single plan that I go to, I meet someone who they had a child who went through it, or they've actually gone through an eating disorder or a sibling. So this is so incredibly prevalent. We think about 30 million Americans, right?
Welcome to the Healthcare Grind, where we cut through the noise in the healthcare industry to bring you the latest trends, innovations, and insider insights. I'm Jess Harthcock, and I'm joined by my co-host, Lon Hecht, as we embark on a journey to connect early-stage healthcare companies, payer executives, and investors with the knowledge and perspectives that matter most. Get ready to grind in the fast-paced realm of healthcare innovation. And for more advanced content, go to healthcaregrind.com.
Hi, everyone. This is Lon Hecht. I'd like to welcome you back to the Healthcare Grind. I'm joined by my co-host, Jessica Harthcock. Jess, give a shout out.
Good morning, everybody.
Thank you. And we have a great guest today, Joan Zhang. Joan is the co-founder and CEO of a company called Arise. Arise is a virtual first support for patients with eating disorders. So, Joan, could we kick this off, first of all, with a good morning? And I'd love to, if you could do maybe a 30 to 60 second elevator pitch for us to get started.
Absolutely. Good morning. My name is Joan Zhang. I'm our CEO at Arise, and we are really focused on supporting the 30 million Americans who will be diagnosed in their lifetime, probably 4x that who are underdiagnosed currently, and 80 to 90% of people will not be able to access care because care is incredibly expensive. There are very limited spots. And so Arise exists to change that. We really look to bring eating disorder care to people earlier so that people can really find healing and avoid that really expensive residential inpatient stay.
Joan, that's awesome. I think that's so needed. Can you tell us a little bit about yourself, maybe why you founded the company as well? Everyone knows I love a good founder story.
Absolutely.
Everyone knows. Everyone knows.
I know. I love to get to know our guests, people. It's my favorite.
The human part of startups is, I think, what's the most exciting and fun part. So for me, I actually developed an eating disorder when I was a freshman in college. I probably lived with one for most of my life, but it wasn't something that was ever talked about in my community. And so it wasn't until I got to college that I fully realized, oh, wow, this is a serious issue. And the suicidality rate with eating disorders is incredibly high. And that was really the main kind of symptom that I experienced beyond the medical implications. I remember just feeling a deep sense of hopelessness because it felt like the eating disorder was really taking control of my life. So I went through all of the barriers of financial barriers, cultural barriers, not having enough treatment options available, having to go to a hospital every single day for treatment rather than being able to do something more accessible from my dorm room. And so ultimately that was my reason for starting Arise was, how do we create a better system that makes care easier for people, especially those who don't understand how treatment is supposed to work, don't have the support of family members?
You know, you brought up something that it really blew my mind. 30 million folks will have or develop an eating disorder. Is that in this country or is that globally? That's in this country, correct?
That's in the US alone. It's estimated 9% of the global population will have an eating disorder. We see a lot of countries, I am Asian American, so I look a lot at, the studies in East Asia and increasing prevalence there as well. I actually just had someone reach out from some of the countries there just asking about what we're doing for treatment. So it's incredibly prevalent globally.
So most of the treatment, I mean, if you go back maybe 10 years ago, most of the treatment, I believe, was more residential or programs that you went to. So can you tell us a little bit about what those programs look like and then how does your program compare? And the other thing I'd love to understand is, where do the economics lie? Is that something that typically resides is it on the patient, or is that something that an insurer typically covers? And I would believe it does, quite a bit fall there. And I'd love to know what the differences are. So I just threw you like 87 questions in there, but why don't we start back with, kind of who's responsible for paying for this? And then what's the difference in person versus a virtual first program?
Yeah, absolutely. So let me start with the cost division. So usually when it gets to residential or inpatient, a lot of it does fall on the health plans. It's incredibly expensive. We've seen that the rates have skyrocketed since the pandemic and haven't really come down. And so, a lot of it is the burden is on the health plan. Unfortunately, though, a lot of times for patients, they go through all of the different barriers to even get that approval from insurance. So I actually was just talking to a parent recently who was trying to get their child into residential treatment. And the treatment center said, we don't have any availability right now. It's probably a 4-week wait for a spot. And we also can't go get your single case agreement until we have a space available. So imagine that. That's a month of waiting for a spot probably longer because it's unpredictable when the spot will open up. And then it's also multiple months potentially of just waiting to hear back about the single case agreement. And during this time, this child is probably going to be hospitalized. And so, really with the rise, what we're thinking is that doesn't make sense anymore, right? We need to actually work more at that intensive outpatient level. So that way we can actually cut costs not only for the individual, but also for the health plan. Think about avoiding the $80,000 residential inpatient stay. There's substantial cost saving opportunity there. When you think about a program like ours, where, we're looking at, more of a $15K case rate for the year. And I think one other piece I want to highlight too is that residential treatment stay is typically maybe 2-3 months long. And oftentimes there's very limited longer term support. So it's often, unfortunately, called this revolving door of treatment because people are not getting better. So it's multiple cycles of that $80,000.
Can I just ask one quick thing? Could you just tell our audience what a case agreement is? Just because not everyone's going to know what that is.
Sure thing. So sometimes, these higher levels of care, they aren't fully covered by insurance. So you negotiate kind of a one-off with the insurance company. A lot of times for single case agreements, there are very strict criteria that need to be met. And so I know in many people's experience, if they haven't experienced a significant amount of weight loss in a short period of time, they oftentimes won't even get that approved. And so a lot of people who are maybe experiencing things like binge eating disorder, where they aren't necessarily medically underweight, they often won't be able to get insurance coverage for treatment. And so they're left just really struggling. And I think an important stat is only 6% of people with eating disorders are actually medically underweight. So vast majority of people suffering don't actually meet that underweight threshold that we think of.
Got it.
So you mentioned something earlier that kind of made my ears perk up, and it was about the revolving door of just, the constant, these patients, they're going to come back. If they don't get the proper treatment, they're going to be back, and it might last for months. It might last for years. So tell me about the recovery. How does your program get patients to recovery? Is it because it's a consistent thing in their life where they're able to see their treatment team with your program? What does recovery look like? How many patients with eating disorders recover? I'm really intrigued by that piece.
I have the belief that everyone with an eating disorder should have the opportunity to recover. And I think the reality right now is that because of how exclusive and inaccessible treatment is, not everyone has that opportunity. And so with Arise, I think there are 3 main pillars we really think about. The first is making care flexible and person-centered. So what that means is most of these residential programs and most of the programs that are out there for eating disorders have very strict time requirements. It's, either 40 plus hours or full time in treatment, or even in some of the IOP PHP programs, you have to do at least 10 hours a week of treatment, sometimes 5 hours a day. And so oftentimes people who are working, I think any of us probably would have a hard time with that because we have a lot of other responsibilities. And then I think about all the people who are on Medicaid or lower income who are balancing multiple jobs. It just becomes really impossible for them to be able to be successful in treatment and stay in treatment. The second piece I really like to highlight is our care advocates and this concept of community care. And for us, that is really peer support based. It's really finding someone who understands what you're going through, both from the actual eating disorder, but also some of the intersecting identities. How does your neurodivergence maybe intersect with the eating disorder? How does your cultural background really intersect? And really can work with you one-on-one on navigating some of that. And then finally, the piece is our maintenance mode. And so that is a distinct period we call our recovery and real life phase. So when people are done with that active clinical phase with us, that typically involves our therapist, dietitian, psychiatrist, primary care doctor, we want them to be able to carry forward this healing for themselves. Like ultimately, we want to give them the tools, but we know that things are going to come up. So during that recovery and real life phase, they still have their community of other members to really rely on, to be able to share advice with that's moderated by their care advocate. And they can also still reach out to their care advocate for, when things come up, like they have a family dinner coming up and they know that, great aunt Sally is going to make a really wild comment. They have someone to process that way that feels really safe. So all of that in combination really just allows us to deliver longer term recovery for people that stays with them and ultimately prevents them from going back into higher level of care.
That's great.
Well, I was going to do a shout out to my version of Aunt Sally, but I won't do that. I'll keep the dirty laundry of the family to themselves. Although I do have a shout out in mind, but I won't do it there. So it sounds like you have maybe 2 phases of your model. You have maybe an initial phase and a maintenance phase. Is that correct?
Yeah, absolutely.
So how long is that first phase? Is it 12 months? Is it 3 months? And then how does that work? Because from a payer perspective, the one thing I'm going to want to understand is how long is somebody going to be in active treatment? So I'd love to understand what that looks like.
Yeah, absolutely. So with our program, the active clinical care phase is typically around 6 months on average. And we say on average because everyone's going to have a different experience. Some people might need a little bit longer. Some people might be done. It depends really on both the eating disorder type that they have and also the acuity level that they're coming in with. So for someone who's maybe needing more of an IOP level of care, but we're, flexing to support that, it might be a little bit longer. For someone who's truly outpatient, this is more trying to prevent them from needing to escalate higher. It could be shorter. And then we have that maintenance phase that we typically have another 6 months for. So our goal is to really make sure that there's at least a year of coverage, so that they can really prevent that relapse. We can really prevent that relapse rate from happening because that year and a half mark tends to be when folks will relapse.
If there's a third phase that should be thought about, maybe, quarterly check-ins or something like that to avoid that in the future. But maybe we'll just have you answer that. And then Jess, why don't you jump in?
Yeah, definitely. I mean, I think for us, we have a digital mobile app that we're about to launch actually next month. And the goal there is to actually be able to give someone longer term tools and support. So we have clinically tailored content that our clinicians develop. And what we do is actually look at the clinical assessments that each member is doing throughout their entire care phase. We look at which were the symptoms that were hardest to really improve and were really severe throughout their clinical journey. And we actually provide tailored content for the individual to complete, as they're going through that maintenance phase. And even beyond maintenance, they can still access those clinical tools. That content will still continue to adapt with them. And so really, we're trying to provide tools that people can use for an entire lifetime.
That's great. So, Joan, I hear you talk a lot, and not only do I hear the passion, but I hear results. So talk to us about the results that you've shown, how many plans you guys have worked with. I mean, I really want to dig into the meat of what you're showing. And I think that's also just fantastic to highlight for listeners and startup companies that want to get to where you all have gotten to in your journey.
Absolutely. I'm an incredibly results focused person. Anyone who knows me will tell you that. And so our first year was really focused. I'm like, this has to be working. Our first year was really focused on clinical outcomes because first and foremost, we're developing this really innovative and new model of care. We need to make sure that it's actually working for people. And so I'm incredibly proud that not only have we seen that this is working, we see about a 50% reduction in eating disorder symptoms as measured by the EDEQS. We also measure PHQ-9 and GAD-7 for anxiety and depression. We also see really strong reductions there. We also look at quality of life and see really significant improvements there. So all of that together, we see that the program is working, but I think most importantly that it's working in a really diverse population. So it's not just, the folks who are struggling with anorexia who have all the means to be able to afford self-pay. It's about 40% people who are on Medicaid or Medicare. It's 50% of people who are BIPOC. It's, people from all different ages. Right now we're adult, so we're 18 plus, but we see folks 18 to all the way in their 70s. And we're actually about to launch our teens program next month. And then I think really importantly too, it's hearing some of the member testimonials where they say that, this is the first place that they felt safe. They feel like their care team actually listens to them and they're not telling them, this is exactly how this is done. This is the modality that we practice. It's a very one size fits all approach. We actually really adapt our program to be personalized to each individual, and people are getting better. People are able to access care and healing for the very first time.
That is fantastic. I mean, that's so impressive to have such fantastic early results. And, just to hear about the folks that you've helped and how exciting that you're getting ready to launch a teen program too. I can only imagine the need for that.
We have had so many parents and teens reach out for support. That's a huge area of need. And so we're really excited to now be able to support those members. And, I think importantly, I launched our teens program when I was at Ginger and Headspace before starting Arise. And I think really importantly for our model, it is, yes, we want to include the family whenever the family is available. And also when that parent figure or the caregiver is not available because they're working multiple jobs, because there's a language barrier, because, the parent is just, there's not a healthy relationship there. We want to make sure that teens still have access to healing. And so that's a really big part of our model is really personalizing to the circumstances.
So a question for you. How are you contracting with plans? What does your model look like?
Yeah, absolutely. So we're actually in network with about 15 health plans across Texas and North Carolina right now. We're going to be launching in New York and Florida pretty soon, and several new states to come this year. So a lot of exciting expansion. And, typically what we really do is we actually go through value-based care contract structures. So that can look like a couple of different variations for us. Typically we do a case rates for a full year of coverage. We also explore things like PEPM models, and we can really get flexible. I mean, I think ultimately our goal is to make sure that people can access care on the basis that they need rather than what they can only afford. So we have a lot of times members will maybe just not attend the frequency of sessions that's recommended because they're worried about those copays, because that adds up over time. And so what we really are looking at with these value-based care contracts is how do we bring that all together so people are actually able to get care and get better much more efficiently than they would in a fee-for-service structure.
Hey, I'll give a little shout out to another episode we did with Mike Ruiz. I think it was episode 4. It was about getting in network. Might be a good one to take a listen to. Mike is ex Aetna. He's over at Vitalize right now, but some really good feedback, just about how to get into network. And then, when you get into the value-based structure, what does that look like? So just something to throw out there. That's fantastic. Jess, sorry. Did you have another question?
No, just about, yes, I guess. About the health plan contracts that you've been able to, get today, what does that next level of expansion look like for you?
Yeah, absolutely. So I think for us, it's a couple different things, expanding to new populations. So the teens program is certainly a big one. But then also expanding our geographic coverage. So as I mentioned, we're in 2 states, about to expand to 4 states pretty soon. But we want to be able to expand not only nationally, but I mean, longer term, it would be great to be able to even expand globally. Like we've had interest from people in Canada, the UK, in, Asia. And so I think there's a lot of potential there longer term. But right now we're really focused on some key states. And the reason we've done that is because we want to really demonstrate that we are partnering with the provider networks and the communities around us. We're not trying to take over everyone's patients. That would be really irresponsible. We're one provider group, right? But what we really are trying to do is when someone has an eating disorder, refer your patient to us. We're going to get that eating disorder stabilized, and we're going to refer them right back to manage their co-occurring trauma, anxiety, depression to the local providers in their community. And I think it really takes collaboration for us to ultimately help people get better and get the care that they need.
People are always afraid of disintermediation with their primary care providers. So how do you keep people engaged? How do you keep the primary care provider engaged in treatment?
Yeah, absolutely. So we actually have a primary care doctor on our staff as well. And they typically act as a consultant to the on-the-ground primary care doctor. So if we need, for example, vitals to be drawn in person, or, get their weight or their blood pressure checked, we will send them to a local PCP to really keep that monitored. And then our providers really provide that consultation of here are the specific labs that we want drawn, or here's how to actually do a blind weight to make sure that we don't actually re-trigger the member. So, to my point earlier, we really look to collaborate with these local providers, and we're not trying to take their patients away. We're actually trying to really keep them in the same ecosystem and work together to make sure that this member gets stabilized. And I think it's a really huge sell to our provider partners, because ultimately it's really complex for them to try to manage these high cost, high risk patients. And so we can really provide that additional support so that it can ultimately manage them longer term once they're stabilized.
Jess, do you mind if I jump in? I just had one other thing that was really top of mind here. I want to throw a little bit of a curveball at you. And when you think of health plans, it can be challenging. Jess and I have both done the early stage entrepreneurial route before. And they don't always come along as quickly as you would like for them to. And something that you and I see as a no-brainer, like I see what you're offering as a no-brainer, right? Something that clearly makes sense. It's much more accessible. It's significantly lower cost. I'm assuming it has, and maybe it's an assumption, has equivalent, if not potentially even better outcomes. The question is, why are payers not going to move on this very quickly, right? And they all have their reasons, but a lot of it is just, they're just challenging atmospheres in which to work. So my curveball to you is, you've got a lot of early stage, or you have payers listening to this podcast. What can they do to help you move this along more rapidly in their organization? I'm sure you hit roadblocks all the time. How can they help? And where are the roadblocks?
Yeah, absolutely. I think that the main thing is really getting the foot in the door. I think I don't come from the health plan world. And so I come from the product and tech world. And so I'm, really building a lot of these relationships with different health plan partners. And I think what's really fascinating is the more I've shared my own story with recovery, every single plan that I go to, I meet someone who they had a child who went through it, or they've actually gone through an eating disorder or a sibling. So this is so incredibly prevalent. We think about 30 million Americans, right? Like we don't often hear people talk about eating disorders though. And so I think really an ask to the folks who are listening is if you have a connection to this space, if you've been personally impacted, I would love to connect with you one-on-one and just hear your story and really just understand how can we collectively work together to create a better model of care for our family members, for ourselves. Because I think that's really where it starts is people who deeply understand the problem space and how difficult it can be to recover, who've been through it. And so that's, I think, the first ask. And I think the second piece is, as we expand to New York, Florida, we're looking at Massachusetts, California. If you are in any of those states, I would love to also just connect and also just hear a little bit more about what are some of the key challenges that you're seeing in your state. And also, what are some of the opportunities that we can really have to partner with local health systems, provider groups to really make sure that we're getting the word out and that people are accessing this care before they're landing in the ER?
Joan, what lines of business is this kind of best served through? Is it commercial? Is it Medicaid? What's the prevalence like in the different lines of business for plans?
Yeah, absolutely. So we actually serve both commercial and Medicaid. And I think traditionally folks have thought that commercial plans would typically be where you see eating disorders, but within the Medicaid community, it's incredibly prevalent because we see that it's actually twice as prevalent, but people are only a third as likely to be able to access care compared to our commercial populations. And that's because in most states, there are no providers who will accept Medicaid for eating disorder care. I was actually just looking into this for a patient in North Carolina who is on a Medicaid MCO plan. And I was just looking at North Carolina. What are all the options? There are literally no other options besides Arise right now. And so that is a key gap. And I welcome more solutions to go take Medicaid, right? Like, please, because people are really in need. And so for us, a big part of it is not only do we go and network with Medicaid, but how do we actually structure a care model that is much more flexible? So for example, folks who are on the foster care system, they don't have parental figures or caregivers who can maybe dedicate that 5 hours a day to treatment. So we really need to think about alternatives to make sure that they can find the support that they need. I also think about folks who are experiencing food insecurity. A lot of times you go to eating disorder programs, they provide all the meals. It's all nicely packaged and it's very, it's all like organic, nice, nutritious meals. But oftentimes that's not necessarily accessible to people. So I think really importantly, we have dietitians on our team who specialize in food access and how to navigate your SNAP benefits, who provide really realistic meal plans that are still very nutritious and really allow for recovery to seem realistic longer term.
That is so interesting for to think about. That's not something. So I'm going to be honest. I'm one of those people that kind of assumed commercial would be a larger line of business just because I guess of the age and the demographic information. So for Medicaid, what percentage of membership is there? I mean, how many of those, and I also found it fascinating that you said you're the only provider group that can serve in North Carolina. I mean, we're missing the boat for these patients. So what percentage of members are you serving in Medicaid? And, you talked a little bit about some of the special circumstances that might need to be considered with Medicaid and how your program tailors to that. Can you go a little bit further for me on that? Because I'm just finding that kind of shocking, as you can tell. I mean, that's shocking that my heart goes out to them.
Yeah, definitely. And I think one of the reasons that a lot of times plans don't see it is because if you don't have any providers who are accepting Medicaid, people are not going to show up. And people oftentimes also have a deep distrust of the systems that are available because they've been told no over and over and over again. We don't accept Medicaid. We can't support you. And so a lot of times for us, it's really repairing that trust with people. So right now in Arise in Texas, we see about, I would say like 25-30% of folks who are on Medicaid. And then in North Carolina, it's actually much higher because there are no other options. It's around, I would say like 50-60% of our members are on Medicaid. So we have a really deep focus on supporting members there. I think one important piece is it's not enough to just do your flashy Instagram ads and, all your paid advertising. I think with our Medicaid population, it's so important to actually go into communities, meet people, share stories and experiences. And so an example is in Texas, we partner with one of our Medicaid plans to actually just go to they have a baby shower that they host. And we know that in that period of pregnancy, folks are actually really susceptible to eating disorders because they have a lot of hormonal changes, their body's changing. There's a lot of, emotional aspects of pregnancy. Gestational diabetes can often be a really intense trigger for people. And so it's such an important period. And yet there are not even, no eating disorder options. There are very limited mental health options for these communities. And so when we go to these events, it's bringing, people who can speak Spanish because that's a, very prevalent language in Texas. People who look like our communities who can actually share their own experiences and stories to really help people open up, about, their own experiences with disordered eating. Oftentimes we are the only or the first people that people are actually sharing their experiences of disordered eating or eating disorders with.
So, hey, Jess, I'm going to jump in here for a minute just because we do need to wrap up shortly. And I just want to get a couple of quick things out there, if you don't mind. One is, and we'll do this kind of rapid fire. And this is not because you're not answering in a quick manner. You're doing a great job with that. I just want to be clear. But, one, employers, is there a strategy, just yes or no? Are you selling to individual employers as well?
Absolutely. So, if anyone out there is an employer, would love to connect.
What about fee-for-service Medicaid? Are you able to access that? Have you had any luck in any of the states you've been in?
Yeah, we absolutely do fee-for-service for some select plans. I think ultimately our model is best suited for a value-based care model because of the care navigation, because of the peer support that's involved, and because of our kind of phased program. But we do offer fee-for-service when it makes sense.
Okay. And my last question is there any barrier for you to be able to offer your services in all 50 states? I would think virtual first. It would be more about getting people licensed in each individual state and also being able to put those supports down on the ground. So if you have folks that are listening in states that you have not mentioned, there's no reason they shouldn't reach out to you, correct?
Absolutely. Please reach out because we're always looking at potential opportunities to pilot and launch in a state. I think for us, it's really about keeping focused and making sure that we're delivering really personalized care because every state is very different. And so we want to make sure that we're really tailored to the unique needs of each state. But absolutely, we're looking at expanding pretty quickly next year. And so would love to get connected. Awesome.
Joan, what is the best way for people to get in touch with you?
Absolutely. So my email is Joan, Joan @wearise.com. And then also our Instagram handles are @JoinArise. I think that's our handle for almost every single social media platform. But I would love to get connected. Email's often the best way to reach me.
Okay. Nothing would make Jess and I happier than you getting outreach from plans and others that are interested in expanding your services because we absolutely love what you're doing. This has been an enlightening episode. We really appreciate having you on. So once again, we're going to sign off in a second. Lon Hecht and Jessica Harthcock from the Healthcare Grind. If you'd like more advanced content, please go to www.healthcaregrind.com. Please subscribe on your favorite podcast app. We really appreciate it. Joan, thank you so much for joining us.
Thank you for having me.
Thanks, everyone.
As we wrap up this episode of the Healthcare Grind, we want to thank you, our incredible audience, for tuning in. If you found today's insights valuable, don't forget to hit subscribe and leave a review on your preferred podcast platform. Your feedback fuels our grind. For more exclusive content and updates, visit our website, healthcaregrind.com. Until next time, keep grinding, stay informed, and lead the charge in shaping the future of healthcare. This is Jess and Lon signing off from the Healthcare Grind.